and gentlemen, under the aegis of Mumbai Hematology Group, myself, Dr. Manoj from Intas Oncology, takes this proud privilege to welcome all of you. Today, topic is malignant histiocytosis, challenges in clinical management, and we assure you that even this rare disease deserves unrare attention. All this has been possible because of untiring work of our program director, none other than Professor Dr. M.B. Agrawal, sir, teacher of teachers and institution in himself, who has coordinated at a global platform to bring in the best of the best across the world. And we're extremely grateful to you. No wonder that you have been awarded the rarest of honor as Inspiring Hematologist of India by Economics Times, and also very recently Guru Dronacharya Award by Indian Leukemia Academy. A proud moment for me to welcome somebody who is a great clinician, and I can humbly say a great friend, none other than our moderator, Dr. Satish Kumar. We know him pretty well. He is a senior consultant hematologist and hemato-oncologist at prestigious Manipal Hospital, Bangalore, an MBBS, MD in internal medicine, and a gold medalist in DM clinical hematology. Many awards and accolades and contribution to the field of hematology and bone marrow transplant in particular. He secured the top position in DM hematology examination at Mumbai University in 2007, and then went on to do his inning at Columbia Asia and then subsequently Manipal Hospital. May I request Dr. Satish Kumar to initiate the entire process as a moderator, please.
Thank you, Dr. Manoj, for those kind words. Good evening to all our colleagues and friends from all over the world. Today, we have three guest speakers, Dr. Jatima Abekun from Mayo Clinic, Dr. Diana Fournier, Executive Director of Histiocytosis Association, Dr. Katie Wisniewski from Histiocytosis Association and Histiocyte Society. This webinar is brought to you by Mumbai Hematology Group. Today's webinar is supported by Intas. It is managed by Perfect Square. I thank Dr. Manoj and his team from Intas for supporting this educational activity. Today's webinar is supported by Intas. I also thank Mr. Yash, Kalpesh, and the team Perfect Square for conducting this meeting, Executive Committee of Mumbai Hematology Group, our guest speakers, Dr. Jatima B. Abekun, Dr. Diana Fournier, and Kathy. All our discussants who are themselves eminent hematologists or medical oncologists from India and abroad, and all you participants for sparing your Saturday evening if you're from India, and morning and afternoon for those who are from the rest of the world. Tomorrow morning, Sunday, 19th May 2024 at 11:30 Indian Standard Time and UK time 7 a.m., we have Dr. Austin Kulashekar Raj talking to us on therapeutic landscape in MDS newer developments. And it is my privilege to introduce our discussants briefly. We have a galaxy of them. I'll just briefly introduce them. Dr. Abhishek Purohit from All India Institute of Medical Sciences, Jodhpur. Dr. Akshaya Mandulai from Mumbai Reference Lab, Mumbai. Dr. Amrit Kaur from Kokilaben Dhirubhai Ambani Hospital, Mumbai. Dr. Anand Raj Vaiti K from MGMCRI, Pondicherry. Dr. Anju Bharati from Banaras University, Varanasi. Dr. Ankur Ahuja from AFMC, Pune. Dr. Arihant Jain from PJMER, Chandigarh. Dr. Chaitra Madiwale from PD Hinduja Hospital and Medical Research Center, Mumbai. Dr. Tebadrita Roy from MedGenome, Bengaluru. Dr. Deepak MB from Narayana Health City, Bengaluru. Dr. Gopinathan M from MGM Healthcare, Chennai. Dr. Hinin Mia Tanda from North Okalapa General Hospital, Myanmar. Dr. Hormaz Zia Soli Sadri, Director, Indian Red Cross Blood Center, Navsari. Dr. Jyoti Sane from Gujarat Cancer Research Institute, Ahmedabad. Dr. Kunal Chattani from Nagpur. Dr. Kunal Goyal from Actrek, Mumbai, Dr. Mallikarjun Kalashetty from Manipal Hospital, Bengaluru, Dr. Manu Vimalachandra, University of Colombo, Sri Lanka, Dr. Meenakshi Suri from Jammu, Dr. Muhammad Tahi Ali Khan from Medicover Hospital, Hyderabad, Dr. Myat Marlar Shwe from Myanmar, Dr. Pujita Baireddy from Care Hospitals, Hyderabad, Dr. Prerna Chaudhary from SMS Medical College, Jaipur, Rajasthan, Dr. Prerna Chautmal from Bombay Hospital, Mumbai, Dr. Pushpanjali Oja from Rajendra Institute of Medical Sciences, Ranchi, Dr. Ramesh Balasubramanian from Madurai, Tamil Nadu, Colonel S. Venkatesan from AFMC, Pune, Dr. Savitri Singh from PGI, Noida, Dr. Shivani Joshi from Nashik Hematology Services and Mumbai Onco Care Center, Nashik, Dr. Shubhangi Agele from Grant Medical College, Mumbai, Dr. Tushar Segal from All India Institute of Medical Sciences, Delhi, Dr. Udayan Kachi from Vadodara, Gujarat, Dr. E. Mon Thand from Myanmar. It's a pleasure to introduce the first guest speaker, Dr. Jitima P. Abekun. He has already educated us last week on the management of Erdheim-Chester disease last Saturday. For the sake of people who have joined for this webinar, Dr. Jitima Abekun is an assistant professor of medicine and senior associate consultant in the Division of Hematology at Mayo Clinic in Rochester, Minnesota. He received his MD from the University of Kansas School of Medicine, followed by a residency in internal medicine and a fellowship in hematology medical oncology at the Mayo Clinic Graduate School of Medicine. His research interests include rare blood cancers such as lymphomas, plasma cell disorders, and histiocytic dendritic cell neoplasms. He currently serves as the co-chair of the Mayo Clinic Histiocytosis Working Group, and in addition to patient care, is involved in several translational research projects that relate to the integration of precision medicine into clinical practice. He has published several peer-reviewed scientific articles in hematological malignancies and was a recipient of numerous accolades, including the Mayo Brothers Distinguished Fellowship Award in 2022, the Young Investigator Award from ASCO 2020, and the Conquer Cancer Foundation of ASCO Merit Award 2018 to 2022. As a clinical investigator, he aims to understand better and delineate disease biology, characteristics, and clinical outcome of patients with these rare malignancies, focusing on identifying new treatment strategies and biomarkers. Today, he'll be lecturing us on malignant histiocytosis, challenges in clinical management. Over to you, Dr. Jitima.
Thank you very much, Dr. Satish Kumar and Dr. Manoj Kumar, and thank you for the panel in giving us this opportunity to deliver this talk. And can I share my screen? Can you see my screen?
Yes.
Is it in full
Yes.
full screen presentation mode? Okay. And can you hear me well?
Yes, Dr. Jitima.
Okay, great. Thank you. So today I'm going to talk about malignant histiocytosis. As Dr. Satish Kumar mentioned last week, I talked about Erdheim-Chester disease clinical management and Rossi-Dorfman disease and Langerhans histiocytosis. I touched on those. And last week I talked about 1.5 hours or so. Today the lecture this talk will be a little bit shorter than last week, just for the reason that malignant histiocytosis is still an evolving field and the clinical management is still evolving. So this is all sometimes are not empirically driven or not validated by prospective clinical trials. So therefore, I'm open for discussion, questions, and let's learn this together, because full disclosure, I'm not a true expert on malignant histiocytosis, because this is always, when it comes to these patients, we always ask questions from all our providers here, like how to manage and what best to do. And I'm not going to address much about the pathology. Dr. Aishara Ravindran has talked about pathology side of histiocytic malignancies, including malignant histiocytosis. So conflict of interest wise, I have nothing to disclose, but I will be talking about off-label drugs. So the learning objectives would be get to know the common presentations and classifications of malignant histiocytosis and understand the molecular pathways and also understand the treatment landscape of malignant histiocytosis. So first of all, this is the same slide I used last time too. Just to identify what is the cell of origin of these cancers. The cell of origin can be different based on new literature. However, what the paradigm is, this is a blood cancer. The cell of origin is a myeloid origin, so hematopoietic stem cell, lymphoid, myeloid, and then it is a myeloid originated cancer coming from monocytic macrophage dendritic cell lineage. And this is the histiocytic classification, L, C, R, M, and H group. And last week, I talked about the L group mostly, and also R group, Rosai-Dorfman disease. And then today, this lecture will focus on the M group, where the malignant histiocytes resides. So there are three main classifications based on WHO. It is histiocytic sarcoma, interdigitating dendritic cell sarcoma, and Langerhans cell sarcoma. And then there is an HS classification, indeterminate cell sarcoma. I will mostly focusing on these three classifications today: histiocytic sarcoma, interdigitating dendritic cell sarcoma, and Langerhans cell sarcoma. And this is, so these sarcomas, so when it comes to the word sarcoma, first thing comes to our mind is soft tissue and bone sarcomas, like osteosarcoma, even sarcoma, liposarcoma, and so forth, which are much more common cancers compared to the histiocytic sarcoma, so malignant histiocytosis. However, when it comes to malignant histiocytosis, these are very rare, but the cell of origin is mostly a blood or hematopoietic cell compared to the soft tissue or solid tumor sarcomas, where it comes the cell of origin mostly a soft tissue or bone or lipid or muscle cell of origin. So it's a very rare cancer, and the prevalence is unclassified, less than 1 per million per year in the United States, and WHO classifies this as three disease groups: histiocytic sarcoma, Langerhans cell sarcoma, and interdigitating dendritic cell sarcoma. And then Dr. Ravindra in her lecture mentioned in her publication here in 2023, there are three distinct types of pathologic classifications as well. But today we will focus on these three specific subtypes. And so with respect, we will talk this in detail, but with respect to mutation landscape, as we all know, in Erdheim-Chester disease, Rosai-Dorfman disease, and Langerhans cell histiocytosis, the diagnosis and the management are mostly driven by the mutation landscape, the MAP kinase pathway mutations, the BRAF mutations, and the PI3 AKTM TOR pathway mutations. So that what gives the malignant histiocytic malignant flavor. And when it comes to malignant histiocytosis, where the three sarcomas are captured, it still holds true. These patients will have a MAP kinase pathway alteration. These about 70 to 80% of patients. PI3 AKTM TOR pathway alterations are seen in about 1/3 of the patients. And then there are other path alterations such as TP53 alterations commonly seen in this sarcoma patient population, like malignant histiocytic patient population, but we do not see TP53 alterations in Erdheim-Chester, Rosai-Dorfman disease, or Langerhans cell histiocytosis for that matter in that frequency. However, numbers are very small. I will tell you the data. You can go to Dr. Ruan's paper just published in American Journal of Hematology and look at this data in detail. The numbers are low, but we identified there is no significant survival benefit, survival difference, not the benefit, survival difference by having these pathways, unlike alterations, unlike what we see in other cancers such as the pancreas, the breast, and the CLL, and other cancers which harbors the TP53 alterations. So this is the all comers. So in all comers, this is the Dr. Ruan's paper is one of the first papers which highlights about 20-30 patients and can give a informative idea of how these patients, what is the prognosis of these patients that comes, because most of the other literature is limited to case series, so 1 or 2, 3 case reports. So median overall survival for patients is close to 16 months, less than 1.5 years. So this is very important to understand. Erdheim-Chester, Rosai-Dorfman, Langerhans histiocytosis, now it's a chronic disease. Our patients live with the disease. Unlikely our patients die from the disease. But when it comes to malignant histiocytosis or histiocytic sarcoma, Langerhans cell sarcoma, and the flavors of malignant histiocytosis, it is likely our patients will die from the disease. So that is the main difference when it comes to management of these patients. So that means that we don't have effective treatment strategies similar to how what we have in other disease entities, in histiocytic malignancies. That is number one. Number two would be maybe our treatments that we put forward for these patients are not effective as similar to what we see in histiocytic malignancies. For an example, targeting BRAF V600E or MAP kinase pathway alterations in Erdheim-Chester disease or Langerhans cell histiocytosis or Rosai-Dorfman disease for that matter have an overall response rate of 80 to 90%. Progression-free survival is about 3 to 4 years. But if we target the same mutations in histiocytic sarcoma or malignant histiocytosis, we do not see such kind of a response. We do not see such kind of a durable response or deep responses. So that speaks towards the disease biology, although it carries a similar pathway alterations and coming from a similar background, may be very different compared to our familiar histiocytic malignancies such as the Erdheim-Chester and Rosai-Dorfman or Langerhans histiocytosis. So that is the main message that I want to put forward, and that is why we need further research and further publications with the clinical outcomes for these patients. So when it comes to, we have identified that KRAS mutations and TP53 mutations in these patients, and having this mutation or not having these mutations, the wild type gene will not affect the outcomes for these patients per the published guidelines, per the published paper from Dr. Rohan in this year. But remember, our numbers are still very small, close to 20 to 30s, as you can see the number at risk. So this is not a very big paper, big numbers, but this is the most highest numbers that we can get from the published literature so far. You can see that there is a slight trend towards better survival in patients with KRAS and NRAS alteration, but nothing is statistically significant. This is the mutational landscape for malignant histiocytosis. So please refer to my previous public talk last week. So when you look at histiocytic malignancies like Erdheim-Chester, Rosai-Dorfman, or Langerhans histiocytosis, the half of the curve is occupied by BRAF V600E. The other half of the circle, most of this occupied by MAP kinase pathway alterations, and the rest remaining are CSF1R fusions and no mutations. But here, most difference is that 1/3 of the patients occupied by the KRAS alterations, and the others, 1/3 is TP53 alterations. And then NRAS, the BRAF V600 is relatively small, 10% compared to the 50 to 60% what we see from ECD and LCH. And then the rest are PTPN11 and the MAP2K1 alterations are there, but less frequent. And one other thing is TP53 alteration in hematologic malignancies is being seen. Diffuse large B-cell lymphoma, the prevalence is 20 to 22%. You will see in CLL, you will see in other alterations. Waldenström macroglobulinemia, it is about 15 to 20%. However, in TP53, in histiocytic malignancies, when it comes to malignant histiocytosis, histiocytic sarcoma, TP53 alterations are relatively common or a frequent founder compared to other hematologic malignancies, suggesting that this drives an aggressive biology in histiocytic malignancies which is different than its cousins or counterparts such as the ECD, LCH, RDD, or other lymphoma such as diffuse large mantle cell or CL. And this is the alterations that you can see. These are the mutations that is significantly altered on these patients. And when it comes to alterations, more than one mutation is seen infrequently, and fusions, splicing variants, nonsense and missense mutations, insertion deletions are also being seen as variants. So when you do next generation sequencing, you have to pay attention for these to capture these variants appropriately in your patients. How does this present in these patients? So epidemiology wise, median age of diagnosis is 60s. So this is different than ECDLCH, which is a relatively a young patient presentation in 30s, 40s, 50s. But in malignant histiocytosis or histiocytic sarcoma, Langerhans sarcoma, and its counterparts are presenting in an elderly patient population relative to ECD and LCH. So that is one of the differences. And male predominance is seen, and any organ can be involved, similar to ECD-LCH as well, because remember what I talked last time. This is a cancer of a tissue resident macrophage monocyte. So when it can reside in any soft tissue, including the bone, and if it is cancerous, it makes the involved tissue or organ dysfunctional, thus giving the patient the clinical signs and symptoms. So sometimes in patients with ECD and LCH, it can be an incidental finding. For an example, if a patient has a back pain coming from a musculoskeletal origin, they did a CT scan, soon enough, there is a hairy kidney. I just had a patient last week like that. And just incidental CT scan finding, hairy kidneys, then that gives the evaluation for ECD, PET scan, classic bone findings, and here the diagnosis of ECD without presenting signs and symptoms. But when it comes to malignant histiocytosis, histiocytic sarcomas, Langerhans cell sarcomas, these patients are sick. When they come to you, they are sick. They have constitution signs of malignancy. They have lumps, bumps coming out from their neck or the armpits. They have fatigue. So that is why it is less like for these patients to be clinically idle, or less likely these diagnoses to be incidental findings. And patient presentation wise, median duration from symptom onset to diagnosis is only less than 3 months. So this is why this disease is aggressive. So these patients comes with symptoms. So for example, I presented a case for you last week, and sometimes this case ECD-LCH goes undiagnosed for years because these patients have not very symptomatic. But when it comes to malignant histiocytosis, these patients are symptomatic. So their diagnosis is very, very soon from presentation to the diagnosis. And that speaks towards why they have decreased overall survival. Median overall survival for published literature is less than 2 years, less than 1.5 years. And median number of tissues biopsy involved is 2, but range goes 1 to 10. Sometimes when you go to the biopsies, CT guided fine needle aspiration, excisional biopsies, ultrasound guided biopsies, core needle biopsies, sometimes these biopsies are full with fibrosis and you cannot differentiate the diseases. So therefore, some patients need multiple biopsies. Clinical point is, if you need a biopsy to diagnose a disease, do the biopsy. Because after the diagnosis, the patients will be informed about the diagnosis when it comes to malignant histiocytosis, and then we can do the next generation sequencing and get the mutational profiles if adequate and appropriate, and also patient can be informed about the disease and we can plan the diagnosis treatment. So don't be hesitant. If the benefits outweigh the risks, please do a repeat biopsy if the first biopsy is inconclusive. And secondary malignant histiocytosis has been seen in about 1/3 of the patients. So secondary means these patients has an underlying malignancy, hematologic malignancy, and that comes that evolves to be a malignant histiocytosis. So these are the most common cancers that has been seen in these patients. So you can see the lineage switch happens. Lymphoid lineage can go to myeloid lineage. Transdifferentiation can happen. And we have proven, Dr. Ravindran's, Dr. Ruan's papers have proven that there is a clonal relationship and the lineage differentiation can happen. So follicular lymphoma, large cell lymphoma, ALL, marginal zone CLL, and this leukemia was undiagnosed actually in Dr. Ruan's paper. So this is not an AML for that matter. Then MPNs all are there, can go to malignant histiocytosis. And also ECD, histiocytic malignancies, not which is malignant histiocytosis, can also differentiate and go to histiocytic sarcoma. We have the first case. I will show you the first case. We are writing it up for publication. However, the reason this is unpublished data, but I want to empower you with this knowledge is it is important for our patients, when you care for these patients, to know that if ECD becomes, or LCH for that matter, or RDD for that matter, becomes aggressive, always have your differential diagnosis saying that has this disease evolved to something aggressive, because ECD, LCH by definition should not be very aggressive. They are aggressive, but not like malignant histiocytosis. So when you're caring for these patients, if the patient presents with a significant aggressive disease, always have this has this differentiated to a very aggressive cancer, such as a malignant histiocytosis. And the median time between prior malignant hematologic malignancy and malignant histiocytosis diagnosis is about 21 months. Range goes from 5 to 181 months. But look at this. About within 2 years, these can transfer to an aggressive malignancy if it's going to transfer. It's not a common occurrence. It's not a common occurrence at all. But if it comes, please have most patients that I treated are coming from a follicular lymphoma background. They have grade 1, grade 2 follicular lymphoma, and soon enough, it can transform to not diffuse large B cell, that is the most commonly transformed, but to a different entity called malignant history. So organ involvement, I mentioned that any organ can be, and there is, please don't memorize anything here, because there is no pathognomonic organ involvement, and even not pathognomonic findings of bone involvement as we see in ECD in a majority of patients. So lymph node involvement is the most common. Bone, lungs are there. And remember, most these patients had a lymphoma before transformation. So that is why the lymph node involvements could be more common in this patient. And then CNS involvement, maxillary sinus involvement, nasal sinuses, and also heart involvement, mesenteric involvement are always seen. And risk organs, bone marrow, spleen, and liver predicts poor outcomes, and this is common in most of the Langerhans cell histiocytosis as well. So when it comes to risk organ, this includes CNS as well. So unfortunately, I have lost some patients with this, and most of these patients had brain-involved disease. So this is the summary. Histiocytic sarcoma, interdigitating dendritic cell sarcoma, and Langerhans cell sarcoma are the most three common classifications. And genetic mutation-wise, MAP kinase pathway alteration, PI3 and AKT-mTOR pathway alterations are seen. However, targeting these pathways MAP kinase also includes KRAS and RAS. Targeting these pathways may not be very, very beneficial. You always have to have your radar on when the patients can relapse when you target these pathways more frequently compared to what you will see in patients with ECD, LCHO, RDD. One is more important is the PDL1 expression can be seen in these patients with higher percentages. And for some patients, targeting this PDL1 is actually beneficial. I will show you a case report for that. So when you have the pathologist signing for histiocytic malignant histiocytosis, interdigitating dendritic cell, histiocytic sarcoma or LCS, Langerhans cell sarcoma, please ask them to stain for PD-L1 because that might not be a common practice. So, and because that will inform sometimes when you don't have much to offer for these patients, some of these, if the PD-L1 is 80-90%, you can deploy immune checkpoint inhibitors, excuse me, immune checkpoint inhibitors such as Pembro or Nivolumab for that matter, uh, for, and some patients indeed will achieve clinical benefit. And multifocal disease and high risk organ involvement predicts poor outcomes. As I mentioned, 1/3 of patients will have a secondary MH and median overall survival is 16 months. So these are the survival curves. This is the all comers. So these are the all comers with overall survival. You can see the median reached about 16 months. And when it's stratified to unifocal, multifocal, although it is not statistically significant, there is a clear trend that multifocal disease, patients with multifocal disease has poor outcomes compared to unifocal disease. And when it comes to progression-free survival, you can see that my primary MH and secondary MH, things get, although there is no significant difference, the secondary MH do poorly compared to primary MH, and there is a trend. And this holds true in other diseases as well. Secondary myeloid malignancies are poor performers, or and that means poor outcomes compared to primary myeloid. So this holds true, and there is a trend, but it is not statistically significant. And so let's talk about the clinical case here. And when it comes to the reason I am putting this clinical case for you to understand that differences between common histiocytic neoplasms and malignant histiocytosis. So that is one objective. To understand how tumor is evolving from a common malignant histiocytic neoplasm to a malignant histiocytosis. To understand the mutational landscape, to understand the complexity of treatment, and to understand how morbid and mortality is this. Because when you talk to a patient with ECD, LCH, you don't start your conversation with end of life treatment aspect. I tell my patients, most probably, if a patient has ECD, LCH, you will live with the disease. It's like a chronic diabetes kind of a thing. You will die with the disease, but not from the disease. But when the conversations when it comes to malignant histiocytosis are different, because they are expected from the published data, median overall survival is about 16 months. So that's why the conversation with the patient and the patient's family is different when it comes to this diagnosis compared to ECD, LCH, RDD for that matter. Even for other lymphomas, diffuse large B-cell lymphoma is curative for 60% of patients. So that is why these things that I want to highlight these things by a case presentation. So this is actually this is a different lady than what I presented last time. Last week. So a 27-year-old female diagnosed with CNS central nervous system involved Erdheim-Chester disease. Patient presented with headaches, vertigo, diplopia, and left foot numbness, and the brain MR revealed cranial nerve, leptomeningeal, and brainstem swelling. And then so I will put forward the timelines. On October 2021, brain biopsy was done, and the brain biopsy showed signs of specific diagnosis of ECD because strong factor 13A is positive, and it was confirmed by our expert pathologists. And then next generation sequencing was done. Nothing was seen in significantly in the in active variations. However, variant of unknown significance was seen in CSF1R and MAP kinase pathway alterations. Therefore, we commenced the patient on cobimetinib, which is under the NCCN guidelines in the United States on December 2021 at 60 milligrams daily. And then, unfortunately, the patient did not tolerate well, and the dose decreased to 20 milligrams daily due to significant rash and fatigue, and ultimately discontinued due to intolerable adverse effects. So I highlighted this point very well last week. When you give these patients a continuous duration treatment, the side effects are very, 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 very prominent and frequent in these patients. So treatment should not be grievous than the neurons of the disease for those patients with ECD-LCH. So manage accordingly with the side effects. And our patients also had the same side effects. So we discontinued the treatment. And then again on the same month, patients progressed, and then we treated the patient with cytarabine every 12 hours for 6 doses, and the patient significantly developed neurologic decline on the second dose. So patient progressed with chemo. This is ECD, not sarcoma. Patient presented with chemo, and patient presented with MAP kinase pathway inhibitors, because this patient didn't have a MAP kinase bonafide MAP kinase alteration. It was seen in a variant of unknown significance. So this is the ECD pathology of this patient. You can see that, CD163 positive, PAKT positive, phospho-AKT, and phosphorus is negative, and this is the journey. So, and then we started, how do we treat this patient? The patient has progressed on chemo, patient has progressed on targeted inhibitors for MAP kinase pathway. She does not have BRAF V600E mutation, and should we go for transplant, hospice, or targeting the US? And this is very similar. This is not the same patient that I mentioned last week, I promise. So this patient had a CSF1R alteration, a different variant compared to our previous patient. However, through in silico validation, we also identified that this CSF1R alteration also activates the downstream pathway, because this hydrophobic loop, which is the inhibitor of the protein by itself, shifts, thus activating the protein to signal downstream. So you can see the wild type is in the orange, the yellow color, the magenta is the mutation. You can see the shift between the hydrophobic loop, and this is the wild type here. And then when you come to give pexidartinib, which is a CSF1R inhibitor, you can achieve a significant benefit by inhibition. So this is the same slide I mentioned last week. So most patients, CSF1R alteration can be parallel activation of MAP kinase OPI3-AKT pathway, and our patient, you can see from this slide that phospho-AKT is much higher than phosphoric, so meaning this pathway is more active than this pathway, and that might be the reason our patients only had side effects without a meaningful benefit with cobimetinib. So this pathway is active, so we decided the patient to treat with pexidartinib, similar to my patient that I mentioned last week. And indeed, this patient had a very clinically meaningful benefit. She walked out from the hospital. She had a very good quality of life with her family, and she had 2 kids with her children, and you can see the response that we achieved, almost a complete response. And she was fine after within 1 month. She actually had a clinical benefit. Radiographic findings were significant in early, or significantly better in 3 months. Unfortunately, so this happens in January 2022. So from January 2022 to March 2023, almost more than one year and 2 months, she benefited, enjoyed a complete response. We were able to give the best quality of life with dignity for the patient. And then, unfortunately, on March 2023, she progressed. This time when she progressed, she had significant clinical signs: nausea, vomiting, lower extremity abnormalities, central nerve system abnormalities. And then we always, one of the things that we really want to keep in mind is that when these patients come back with signs and symptoms of relapse, always biopsy. Do never ever think that, oh, this is the same disease, because they are muted. Although it can be the same ECD, their mutation landscape can be different, and your treatment approach will be different. So always biopsy and go to the chalkboard and do the next generation sequencing if available, and then decide on treatment. So we biopsied the patient's CNS disease, and indeed we find, I will show you the pathology picture next slide, but we find that ECD now has been transformed to a histiocytic sarcoma. And this is the mutation profile of the first biopsy, which is the ECD, the second biopsy, which is the HS, histiocytic sarcoma. The PTPN11 was there. The POT1 mutation has been completely eradicated. Dicer gone. CSF1R alteration, she had 2 before. Now she was on pexidartinib during this month. So now the tumor has evolved to a different clone. Now the patient has a different CSF1R alteration here. The others 2 are completely gone. TP53 now is seen. Before we didn't. When the patient has ECD, no TP53 alteration seen. Now we see a TP53 alteration. And the rest of the mutations you can see are seen in the second sarcoma compared to first. 2 things to remember here. 1, yes, new mutations can happen. 2, most importantly, I think, my personal belief, see, number of mutations. 1, 2, 3, 4, 5, 6, 7, 8. 8 alterations on the second biopsy and 4 alterations or 5 alterations on the first biopsy. So mutational burden. This is not the same mutational burden as you can see in colon cancer, like the TMB. I'm saying this mutational burden on functional genes are very high when it transformed or when it comes to sarcoma, histiocytic malignancy, histiocytic sarcoma, or malignant histiocytosis compared to ECD, RDD, or LCH. So that might be the reason that we don't see that targeting BRAF V600D, MAP kinase, when it has the bona fide mutations, are not that beneficial in these sarcomas compared to the ECD, RDD, LCH, because the tumors are equipped to proliferate and do the tumor genesis, or not tumor genesis, do the tumor proliferation and survival through parallel pathways if one gets inhibited. So that is why we might not see the same benefit of targeting this compared to what we see in ECD, LCH. So these are the things that I want to highlight. And then this is the pathologist. This is not published. Keep this confidential if you may. So you can see that this is the ECD diagnosis. This is the MH diagnosis, and the expert pathologist who were involved in this case is Dr. Karen Rick and Aishwarya Ravindran. So credit goes to them. But what I want to highlight here is 2 things. The tumor. I am not a pathologist. I am a clinician. For me, under my eye, this looks very angry. Pleomorphic cells, very different shapes and size you can see compared to the ECD on the left. And the 163 positivity is significantly seen here compared to it. So malignant tumor cells are much more higher in the right side compared to the left side. So that is why this is a different beast. And although it transformed, this is a different beast that you can see from here. And so NGS showed TP50 alteration, CSF1 alteration has been different, it's been changed. Now pexidartinib, we actually validated this in silico, and we found that there is no significant. So this is the wild type. This is the first alteration she had, and you have this hydrophobic loop shift making it activate. Now we do not have a hydrophobic loop shift with the second variant. You can see that the magenta and the yellow color overlaps each other, suggesting that pexidartinib will not be active, and that's why the patient progressed on pexidartinib. So PDL1 was 90%, so we were a little bit happy. Maybe we can target this patient with the patient's tumor with ICI, immune checkpoint inhibitors. We treated, patient progressed. Then we put everything under the sun if possible, not doing any harm. But cytarabine, methotrexate, nivolumab, encorafenib, benimetinib, nothing worked. Nothing worked, and the patient died, unfortunately, 2 months ago. So this is the trajectory of the disease. So few things to highlight again. 21 to 23, patient has a relatively indolent cancer, ECD. Patient lived well, patient had the best quality of life. And then this transformed, unfortunately. And look, within few months, patient expired. So that is why this is March. So on 20, so within a year, our research says 16 months was the median overall survival. Dr. Ruan's paper. This is true in one case too. Within a year, patient expired. So the things to highlight here is that when you deal with these cancers, always, if it is aggressive, please make sure biopsy again, make sure if it transformed to a sarcoma or not. If it is sarcoma, if the patient is healthy to the point that he or she can withstand treatment, be aggressive on treatment. Sometimes, unfortunately, our capacity right now to make these patients lives better are very limited. And while I speak right now, I have one patient in the hospital getting treatment before histiocytic sarcoma. The patient has Langerhans cell sarcoma. Unfortunately, it is very difficult situation. So that is why this talk is not a winning talk. Unfortunately, I don't have the pride to put forward saying that, look, we know what is happening, we can get the patients out from their agony of having a disease and give them the best quality of life. But here I am coming to talk to you saying that unfortunately we don't know what is happening. There are some case reports which are very successful and have treated the patients well, which I explain in next slides. But right now our field needs more patients. Our clinicians need to diagnose this more frequently, learn about the disease, learn about the pathophysiology, fund the research that focus on these diseases, and so that in few years, 5-10 years, we will have a good treatment approach for our patients. So now let's talk about treatment. I talk about some treatments. Let's talk about treatment. So this is the treatment algorithm, not algorithm, treatments that these patients were treated in Dr. Ruan's paper. You can see all of the things have been deployed for these patients. The chemo, the targeted therapy, the therapy treated in T-cell lymphomas, the pazopanib, the dasatinibs, everything has been treated. But what you can see here is one thing. Surgery is still the best option if you can afford the patient. So you can see all the complete responses. Most of the complete responses are the surgery, what comes from surgery. That paradigm is similar to sarcoma that you have in other soft tissues. And surgery should only be done in a localized disease. So that is the most beneficial, to be honest. But targeting MEK inhibition is not much beneficial for our patients here, and that's Dr. Ruan's paper acknowledged that if you read it. And other targeted therapies or the chemotherapy is not acknowledged and not that beneficial. Also, one want to highlight that sometimes in sarcoma you amputate the limb, because in sarcomas mostly when it comes to bone, or even sarcoma is now mostly limb sparing. But when it comes to bone, sarcoma is a localized disease, it's not a systemic disease. But when it comes to malignant histiocytosis, remember, it comes from a blood cell. It's come from a monocytic macrophage, which is a systemic disease, although it can manifest in one disease area. If you have diffuse large B-cell lymphoma coming from one node, you don't get it out. You treat the patient systemically. So similarly, in these patients might benefit from systemic therapy compared to getting the limb out or the limb amputation. So make sure you think again if it comes to a limb amputation from the surgeon or from the practicing provider. However, unlike diffuse large B-cell lymphoma, I don't have like a very good options that has a cure rate of 60%. The response rate was 80 to 90% like a treatment to offer for malignant histiocytosis yet, but always have an informed discussion that maybe limb salvage is the best option compared to limb amputation. So don't jump for limb amputation if you see the word sarcoma. If it is malignant histiocytosis, make sure that this is a systemic disease. This is not a localized disease. And there are other case reports actually some patients has benefited well in targeting these mutations. You can see that one case report from New England Journal of Medicine 2018, patient had histiocytic sarcoma transformed from follicular lymphoma, MAP2K alterations were identified, pemitinib was treated, patient achieved a complete response after 2 years of follow-up. Another from JNCCN, the patient had histiocytic sarcoma, KRAS mutated. The patient had this mutation targeted with tremetinib, achieved a good response. after 31 months of follow-up. And this patient actually was treated as a PDGFR alpha and beta alteration and was targeted with imatinib as well. You can go to this by Hu et al. And get more information. But I want to put forward one thing here is that yes, when you have the alteration, target the alteration. But sometimes you will achieve a win, but most of the time don't expect a win, as you may expect from ECD, LCH, and its cousins. So that is why it is important. There are case reports, but and do respond well in some patients. I truly believe this is the case for all our patients, but may not be. And this is one of our experience that we target the patient with ICI treatment, published by Dr. Zanber and in Hematologica. This is actually patient's reports. PDL1 expression was 95%. It is a Langerhans cell sarcoma. You can see the Langerhans positive and CD1A positive and pleomorphic cells. You can see the angry looking cells, which is a sarcoma in HNE. And this patient had this all alterations. TP53 was there, PTPN11 was there, and patient was treated with tremetinib. Unfortunately, did not respond. That is our experience at Mayo Clinic. We don't achieve a durable response when we target these patients. And subsequently, the patient decided on treatment with pembrolizumab, secondary to PDL1 expression, and this is the response. And the patient is doing quite well for long duration. After 1 year of follow-up, you can see that initially it decreases and somehow it increases here. We radiate that area, and then after radiation, it actually responds better. That is a common phenomenon that we all have identified, and you can see that this patient achieved almost a complete response. It's a very good response, partial response. So this is why PDL1 is important. If it is high, it's not wrong for you to deploy ICI therapy. Remember, our previous patient I presented did not respond to nivolumab. She actually responded. She has a CNS involved disease. She had some partial response, but not a durable response, unfortunately. And always remember, this ICI treatment is also comes with adverse effects, as ICI induced inflammatory syndromes so make sure hypophysitis, pancreatitis, thyroiditis can happen, and sometimes hepatitis can happen. So make sure you screen and pay close attention for these patients' symptoms and signs. And how about transplant? There are case reports that these patients can benefit from transplants, autologous and allogeneic. You can read this here, but the thought process is, if you deploy chemotherapy for these patients in a sarcoma setting, if the patient has good chemo-responsive disease, then consolidating with autologous stem cell transplant is not a bad idea. I don't have, to be honest, to show a prospective clinical trial to show that in these malignant histiocytic patients, transplant is better. However, coming from literature from multiple myeloma, coming from literature from CNS involved disease in lymphoma, coming from mantle cell lymphoma, coming from diffuse large B-cell lymphoma, perhaps we can say that consolidating with autologous stem cell transplant in a chemo-responsive patient will have a better outcome if the patient can tolerate the treatment. If the patient is non-chemo responsive and patient is healthy enough to withstand allogeneic stem cell transplant, then entertaining an allo approach of a stem cell transplant is also beneficial, as you can see from this case report. And so successful treatment approaches, in a summary: limited stage disease, always remember surgery, radiation. It's a cornerstone that it's very important to get it out, but perhaps limb salvage, limb sparing surgery is important, but make sure that it has you talk with the surgeon, family, and as a team make that decision. Limb amputation may not needed for histiocytic sarcoma or malignant histiocytosis, as you can see with other cancers. If you have these alterations, beta V600E, MAP2K, CSF1R, PDL1, PTPN11, PDGFR alpha and beta, yes, you can target this based on the literature, because some literature is there to show that this is efficacious. However, my experience is that targeting these will achieve a clinical benefit, but may not be deep or durable compared to what you can see in ECD, LCH, or RDD. Cytotoxic chemotherapy will have a place here, and this cytotoxic chemotherapy would be specifically, what you deploy in the sarcoma setting: anthracycline based decarbazine, ifosfamide, gemcitabine, cladribine, and so forth. So this is my approach when it comes to malignant histiocytosis. First you ask whether patient is symptomatic. Symptoms are there, and risk organ involvement is there. Most patients, the answer is yes. And then you ask BRAF mutation, V600E mutation is there. About 10 to 20% of patients will have. If yes, you treat with the BRAF inhibitor. If not, you have a MAP kinase pathway alteration is there. If yes, you treat with the MAP kinase alteration. Keeping in mind again, the response here might be little inferior compared to the response what you can see in ECD-LCH. And then if you don't have a MAP kinase alteration, you ask the question, do you have other targets, such as CSF1R, such as PTPN11, PDGFR, and so forth. And yes, you can target from the literature knowledge from other cancers, such as the myeloid malignancies, such as the tenosynovial giant cell tumors, and so on. And then the special consideration: if the PDL1 is high, treat with ICI, immune checkpoint inhibitors. Localized disease, consider radiation and surgery. Avoid limb amputation if possible. High response to chemotherapy, if you deploy, consider consolidation with autologous stem cell transplant. And then refractory disease, consider allogenic stem cell transplant. So these are not common in ECD, LCH, RDD management. However, this should be entertained in managing malignant histiocytosis. And the chemotherapy I have used are these with some benefit, but you can use other chemotherapies too that you are treating, you will be used in the sarcoma setting. So doxorubicin, ifosfamide, decarbazine, gemcitabine, cladribine, paclitaxel is also should be here, cytarabine, and other chemotherapies. So in summary, histiocytic sarcoma is an aggressive cancer, and aggressive phenotype compared to other histiocytic neoplasms. Majority will have a driver mutation, but the response to its inhibition can vary. And treatment should focus on a driver mutation when possible. Surgery and radiation are crucial for localized disease. Myeloid and lymphoid malignancies can transfer to histiocytic malignancies, and sometimes malignant histiocytic neoplasms can transfer to histiocytic malignancies as well. And when it comes to secondary malignant histiocytosis, prognosis may be, p-value is 0.2, I understand, but there is a trend. So maybe it is worse in secondary malignant histiocytosis compared to primary malignant histiocytosis. Chemotherapy used in soft tissue sarcoma may have a place in this histiocytic sarcomas and malignant histiocytosis. Practicing team science is important. Get your surgeon, get your radiation oncologist and pathologist. And also when you deploy this treatment with MEK inhibitors and BRAF inhibitors, get your dermatologist to see the patient's skin. And so practicing team science is important, and more research desperately needed in this area. So this is not like a very happy ending for me, unfortunately, but I truly believe in 5 to 10 years with the research everyone is conducting, this could be a happy ending for our patients. With that, I would like to thank all the Mumbai hematology team and everyone for giving us this opportunity, actually. And also, I want to tell one thing which I forgot last week, actually. We have something called Mayo Clinic, University of Alabama at Birmingham Histiocytic Working Group. So this is chaired by myself, Dr. Gaurav Goyal, Dr. Aishwarya Ravindran, and Dr. Karen Rake, and Dr. Ronald Go. So, and we have the pathologist, the radiologist, the endocrinologist. Now for now we have multiple sites in the United States. But if you truly have a case that you want to discuss, please email me. I am our email, Dr. Ron Go. I am really happy to send you the Zoom link. You can come. Your scans can be reviewed by expert pathologist and radiologist. We are happy, free of charge. We are happy to do this service, and it happens every Thursday on every month, second Thursday, or every second Thursday on a month. And please email me with if you have a case to present. I will send you the Zoom link wherever in the world you are. Sometimes it can be 2 a.m. for you, but if it is okay with you and your family, please, we are happy to help with managing these very difficult patients. And with that, I'm open for any question.
Thank you so much, Dr. Jitima Abekun, for that lucid presentation and educating us, updating us regarding a rare and a difficult to treat disease, malignant histiocytosis. We'll take the questions after the other two lectures. I now request Dr. Diana Fournier, who is an Executive Director of the Histiocytosis Association, a global nonprofit that is dedicated to addressing the unique needs of patients and families impacted by all histiocytic disorders. Diana is also a histiocytosis patient herself, having been diagnosed with LCH at the age of 6. In addition to providing educational and emotional support for families and patients and raising awareness around the world, the association funds several research projects each year. Over to Dr. Diana for a talk.
Thank you so much, Dr. Abekun. Great talk. Thank you for your fantastic insights. Just give me one moment to share my presentation. Hopefully it's full screen, and thank you for the warm introduction and the opportunity to be here. So as was mentioned, the association is a global nonprofit located in Pittman, New Jersey in the United States, founded in 1986 by parents whose daughter was diagnosed with LCH, and we support patients, families, and medical professionals. We have many different buckets in our mission. So just to show all the different places that we do provide resources and support, we have, and I'll walk through a lot of these as we go. So I'm going to skip over this slide and kind of go through quickly. But I want to highlight first, you'll hear from Kathy Wisniewski next, who's the Secretariat for the Histiocyte Society. Since the very beginning of both of our organizations, we have partnered for the support and success of research and patients around the world. And so the association serves as a partner secretariat for the Histiocyte Society. And our goal is to alleviate the society's leadership of administrative responsibilities of running a volunteer-based organization so they can focus on the things that they do best, which is the research. So we're really thrilled to have that opportunity for the partnership and very grateful for all the ways that that partnership comes to life. It's demonstrated most importantly for the association during our research funding cycle, where the Society's Scientific Committee conducts a comprehensive review of our applicants and then provides that review to the association's scientific committee. And since 1990, we have funded over $7.5 million in research through the generosity of donations from the community, equating to more than 202 individual projects from investigators in over 12 countries. Really quickly, the patient experience involves a lot of unmet needs. And so we work to continue to survey what those unmet needs are and then to provide programs and support in those areas. So some of the things that we provide are up-to-date disease information for all histiocytic disorders and related conditions. You can see by the image on the screen, we also include things like diabetes insipidus, now known as AVPD, and a variety of other related conditions to histiocytic disorders. We have a searchable resource directory that is international, and we're continuously evolving our programs to meet the needs of the community. Some of the things you might be interested in sharing with your patients and families, or that might be interesting for you, are listed here, such as our wellness and yoga hub. We have our research grant program, educational videos. We have a podcast called Beyond the Diagnosis, which is a phenomenal resource that explores topics beyond histiocytic disorders. A peer support program, we have a grief support program as well, and we're working on acquiring a tool that would allow us to offer those in 28 languages simultaneously. So hopefully we will have that, and we can open that up even more broadly around the world. But we also can help set up local programs for any language. So if there's a group of families that is interested, we can work on building that. We have an international physician directory. So if you see patients for any histiocytic disorder, whether pediatric or adult, I encourage you to scan the QR code on the and our website up at the top, histio.org. You can also explore that and sign up that way, but it is free to put yourself in the directory, and it connects you with other providers as well as patients to you. And we verify every 1 to 2 years to ensure accuracy. And by putting yourself in the directory, we also will then begin to send you information about resources that might be beneficial. We also have a physician resource center, so you can scan this QR code as well if you'd like, or again, explore our website. You can look up histio.org Physician Resource Center to find it as well. Right now, our brochures are only in English and Spanish, but we are working on making that more global. We also have fact sheets, Histiocyte Society information, webinars, care bags for newly diagnosed patients. This is a quick reference page for you so that you don't have to hunt through the site for the most important things. And then if you are interested in applying for a research grant from the association, our application window is open from now until June 16th. You can scan this QR code for the direct link to the information on that, but these are the different areas of interest. As long as it's related to histiocytosis, then it would be relevant for this RFP. So I encourage you to consider that for any projects that you're currently working on. And the funding is $50,000 US per project, and we fund as many as we can. So, and this year we are really focused on patient-centeredness. So if you have a project that's really important to the patient community, we encourage you to consider that in your application. We also have an ambassador program, which are a special group of individuals based in the United States and the UK, but we are open to anywhere around the world to have them work alongside the team to support families, participate in research, advocate for treatment that is maybe not available in that country, and raising awareness for histiocytic disorders. And just mentioning a little bit more about the fact that patients need the support. So encouraging you to share our information or a local family group with your families and patients that you support. I won't read what's on the screen, but you can see that it just means a lot to be able to have that guidance and someone advocating for your care, connecting you to a provider. And even after the diagnosis, there's a lot that comes along with it. So encourage you to connect your patients with a local group or with the association. And then we are involved in a lot of international work. So I'll just mention, we have a coalition for international patient support, and we have family groups that are comprised from different countries and regions, such as Argentina, Canada, France, Spain, Greece, Italy, Japan, India, UK, and USA. And we work on global initiatives together to try to bring different resources to each other and to meet the unmet needs of patients around the world. And lastly, I'll just mention that we love to bring research to life. So if you are an author of a publication related to histiocytosis or something that would impact a patient or family member, like a clinical trial or a related condition or a related topic, and you'd like for us to feature you, we can do an interview and bring that to life. As you can see, we have many of them we've already done, and they have a wide reach. In addition, we hold regular webinars on various topics. So if you are interested in participating in an interview or hosting a webinar, please reach out to us, info@histio.org. We'd love to get to know you and feature your work and bring that to life for the patient, family, and medical community as well. Thank you so much for the opportunity to share a little bit more about the association's programs and services. And thank you all so much for your dedication and support of the histiocytosis community.
Thank you, Diana, for that wonderful presentation and letting us know what the association is doing. You're doing fantastic work. Now I would request Kathy, one second. So Kathy Wisniewski has worked with the Histiocytosis Association and the Histiocyte Society since 2008. During that period, she has held many roles in both the organizations, but today her primary responsibilities lie in managing the Histiocytosis Association Research Grant Program, producing the association's podcast entitled Beyond the Diagnosis, and managing the Histiocyte Society, a global group of 200 physicians and scientists dedicated to researching histiocytosis, finding better treatments, and ultimately a cure. Over to you, Kathy.
Thank you so much. let me get my slides up here for you. Let's see. Okay. Thank you so much for this opportunity to be here to share with you about the Histiocyte Society. I'm excited to be able to share a little bit about the work that we're doing. So as was mentioned, the Histiocyte Society is a nonprofit organization which consists of 250 physicians and scientists from around the world, and they are committed to improving the lives of patients with histiocytic disorders through their clinical and laboratory research. The Histiocyte Society was formed all the way back in May of 1985 with a historic international workshop, which took place in Philadelphia, and it was initiated by Dr. Giulio D'Angio from the University of Pennsylvania Hospital. And this historic meeting led to the foundation of the Histiocyte Society. There were only 15 attendees at that very first meeting. Now, as of April 2024, we have 250 physicians and scientists from all over the world dedicated to the research of histiocytosis. So our mission is to advance the knowledge about and improve outcomes for patients with histiocytic disorders through clinical and basic research and education, which will lead us to our vision to be the world leaders in understanding histiocytic disorders and improving patient outcomes. So where is all of this amazing work taking place? Here is a map of where our members are located. We are all over the world, and I'm excited to say we have 3 members that come from India. And some of our accomplishments include these that are listed here. It's been through this extensive research and collaboration that the Society has made these significant strides in the fight against histiocytic disorders. We've been able to establish a common language of universal disease classification, standardized diagnostic criteria, and guidelines for patient evaluation and follow-up. But there is still much work to be done. And so as we move to the future, the Histiocyte Society recently completed a long strategic planning process and identified several important goals, some of which overlap or support the others. The first one is that the Histiocyte Society wants to become the coordinating organization for all initiatives related to histiocytic disorders. And we're going to work towards this goal by continuing to bring together medical professionals and other groups to encourage collaboration and research activities. We're going to continue to standardize definitions across the various disorders and provide information on access to ongoing clinical trials related to histiocytosis. We also want to increase our visibility among medical providers, scientists, research organizations, and patient groups. And we're going to work towards this goal by improving our website and overall internet presence through social media, more webinars, informational emails, etc., and by attending and exhibiting at other related conferences such as ASHPO and ASH. Our third big goal is to increase our global presence to improve the care of patients with histiocytosis worldwide. And this one is really super important to us because of our overall mission to quicken diagnosis, to improve treatments, and eventually find a cure for all forms of histiocytosis. So the Society is very focused on reaching out to lower and middle income countries and educating them on the best ways to treat their patients based on drugs and therapies that are available to them in their particular country, and then subsequently develop resource adapted treatment guidelines. And then finally, the Society wants to foster the next generation of histiocytosis clinicians and researchers. And we want to make sure that we are raising up the younger generation. And we've started work towards this by already creating a young investigator committee to invite young investigators to become involved in the Society. And we've also expanded our mentorship program. So moving forward, we would love to have you join us if this is something that interests you. There are a couple of easy ways to get involved. You can scan the QR code there. It will take you to our website, which is histiocytesociety.org. We recently started offering a membership discount of 50% for trainees. We do have an upcoming webinar on June 6th that's going to talk about HLH-like toxicities following cellular therapy. And of course, we have our 40th annual meeting of the Histiocyte coming up in person and online, and excited to share that meeting is taking place in Goa, India, November 7th through 9th, with a special education day on November 6th, in which we're going to invite local speakers to talk about various cases And the goal of that is to help to develop guidelines, like I talked about in our strategic goals. With that, I just want to thank you again for allowing us to share, and we hope to see you online or at our GOA meeting. Thank you.
Thank you so much, Kathy. We really appreciate the work done by the Histiocyte Society. The house is now open for questions. I request all our colleagues and discussants who want to ask question for all the three speakers to please put the raise hand sign so that we can start the question and answer session. So meanwhile, Dr. Jatima, there's a question from the audience from Dr. Kannan Ramamurthy. What is the median PFS for Erdheim-Chester disease with BRAF mutation treated by BRAF inhibitors? Second question, what is the longest survival reported?
Yeah, so for BRAF inhibitors treated with in a ECD, actually with the follow-up, most of the time median PFS has not been achieved, because so the clinical trial that is published by Dr. Eli Diamond as 2018, so that has a more 5-6 years of follow-up. But in our practice, after longest is about 3 years of follow-up, the median PFS is not achieved. So around 70% of patients will be progression free after 2 to 3 years of follow-up. And longest, well, the second question was a survival or PFS?
What is the longest survival reported?
Yeah, so the longer survival reported is actually, when it comes to ECD mostly is not a disease with high mortality. So the longer survival is the normal life expectancy of a patient in my mind, So that is why when it comes to ECD, your treatment should focus on give the best quality of life for the patient, so that they will not have the morbidity associated with the disease, such as comes with the organ impairment, the skin rashes, the bone pain, the kidney impairment, and so forth. But most of the time, the patients will live the normal life that they will have. But so that is why these patients should have all the normal follow-ups, healthy life, eating habits, colonoscopies, mammograms, pap smears, and so forth. So that is why it is important to do like a normal general health maintenance exams for these patients.
Dr. Jatima, have you ever stopped the treatment in any patients and followed up BRAF with BRAF?
Yeah, that's a good question. So yes, and it is published too. In when you if you discontinue treatment for BRAF or MEK inhibition after 2 years, 75% of patients disease will come back. And these patients, when you re-challenge it, they will respond. Unlike what you see in CML, we yet to see aggressive, different mutational profile in these patients when it comes back. So that is why it is important. Some 25% of patients will not come back. 25% is not a small number, like 1/4 of the patients will not have not disease come back, but the studies are, have a less follow-up. So theory, it has a good risk of coming back, but it should have more, it should respond to the same treatment. So if a patient has problems with actually withstanding or tolerating the treatment, or the patient say like, look, I'm done, after 2 years or 1.5 years, I want a drug holiday, it is not a wrong thing to do a drug holiday. Closely monitor the patient every 3 months, laboratory evaluations, physical exam, and perhaps if possible a CT scan or PET scan. If the symptoms are there, then you can, if the disease comes back, you can re-challenge.
Thank you, Dr. Jatima. Question from Dr. Narendra Gemawar. Can HC present in pediatric age group as a dermal manifestation? I think
Could be. Yeah, that is a good question. I'm not a pediatrician, but yes, it can. And the dermal manifestation, but rare though. Histiocytic sarcomas are unlike LCH, it is rare in this population. And when it comes to just like with dermal manifestation, rule out juvenile XG xanthogranulomas and like other commonly seen histiocytic diseases before we rule E in the diagnosis, or we make the diagnosis of histiocytic sarcoma or malignant histiocytosis.
Thank you, Dr. Jatima. Another question from Dr. Babita Soji. In how much percentage of patients are positive for PD-L1 and AMP, consequently eligible for immunotherapy, as it is very motivational?
Yeah. So unfortunately, I don't know the percentage because we don't have big studies to show that, but PD-L1 expression is seen, I will say, in our patient practice that we put forward, in about 20 to 30% of patients will have high PD-L1 expression. So this is a very tricky question though, esophageal cancer, lung cancer, we know PD-L1 more than 1% will respond to ICI treatment, right? So one of the ways you treat lung cancer with pembrolizumab single agent, if the PD-L1 is more than 1%, right? However, when it comes to here, higher PD-L1 expression, I don't know what is the higher PD-L1 expression. Is it more than 1%? Is it more than 50%? Is it 90%? I don't know. So, but however, you can say that if it is from our experience, if the 90 to 95% of of PD-L1 is expressed in the pathology, then it is not a wrong answer, a wrong thing to expose this patient to ICI for hoping it will help. So if you tell me if it is above 30% PD-L1, I would advocate for you to treat the patient with ICI and closely monitor the patient. If it is less than 30%, I'm not sure it will be beneficial for the patient.
Thanks, Dr. Jatima. Dr. E. Monthant, do you want to ask the question, Dr. E. Monthant? Okay. May I know your experience? Thanks for an excellent talk. May I know your experience of clonal relationship transformation with MPN and AML? May post-transplant AML change to malignant histiocytosis? Can we use cytarabine-based chemo if pathologist is difficult to differentiate subtype of malignant histiocytosis? So there are two parts of the question.
Good question. So I have not seen a patient transforming from AML to histiocytosis. So I actually, Dr. Ravindran is one of my good friends. So we and Dr. Rake, who are very expert pathologists in the field, we also talked about this frequently. It is unlikely that we see, AML is an acute, early stage of a hematopoietic development, right? It is unlikely that an early stage of hematopoietic development can transform to a mature stage, which is like large histiocytic sarcoma. Similarly, it is unlikely that we see something transformed like an early lymphoblastic cell to a lymphoma. So that is why maybe AML transforming to a histiocytic sarcoma, I am yet to see one. But other mature diseases, CL, chronic lymphocyte, or MDS, MPNs, diffuse large B-cell lymphomas, which are the mature stage, chronic stage of the cancer, and that can transform to histiocytic sarcoma that we have seen. Follicular lymphoma can be transformed, histiocytic malignancies can be transformed to, but that when it transformed, from CLL, SLL, follicular, ALL, so for that matter, to that we have seen, that is an acute form, I agree. That we prove the clonal relationship. Yes, there is a clonal relationship that you can restrict from the immunoglobulin expression. So you can determine the clonal relationship. And that is so answering your question, I haven't seen an AML transferring to HS or malignant histiocytosis, but I have seen follicular lymphoma, CLL transferring to malignant histiocytosis. Number two, cytarabine can be used. Yes, indeed, it can be beneficial. So it is not a wrong thing. So that is why please go to my algorithm that I think I put forward. If there is no alteration that you can successfully target malignant histiocytosis, if that successfully target, you treat the patient with chemotherapy, and padribine, cytarabine are good options.
Thank you, Dr. Jitin. I don't see any other questions. So, Dr. Chitima, does it matter from which disease the malignant histiocytosis transforms from, like follicular lymphoma or MPN? I mean, has it shown any survival difference?
Thank you, Dr. Kumar. No, I don't. I don't know. Actually, I don't know the data. I don't have the data. I don't think there is data to show that it is when it comes from a different disease that is there. It is aggressive. However, but this is very, it needs a very informed decision. So, for an example, if a patient comes, you have CLL and transform to Langerhans sarcoma. This is a true patient. Right now, the patient is in the hospital. This is the exact situation. So then, you can say like, look, if the CLL is indolent, has been indolent for the past, not been treated, now it is a sarcoma, then you treat the patient with sarcoma, histiocytic sarcoma angle, or Langerhans sarcoma angle. So deploy is doxorubicin with decarbazine type of a treatment, or if it is BCL2 inhibition is high, you can actually do venetoclax so that you can be treating the both CLL plus is malignant histiocytosis together, and PDL1 is high pembrolizumab. So those things, or BRAF V600E or MAP kinase pathway operation is there. You can target those. However, imagine if a patient has a large cell lymphoma now transformed to sarcoma, you have to be careful because not everything you see in the patient's body might be sarcoma. There might be a diffuse large B-cell lymphoma in the body that needs to be treated, because diffuse large B-cell lymphoma is not an indolent cancer. It is an aggressive cancer, right? You need to be, so when you come to the treatment landscape, you need to make sure you capture both if possible, if the base disease needs treatment. If the large cell lymphoma needs treatment and now a component has transformed to sarcoma, you make sure that you deploy a treatment angle that can help the both. And so, for an example, I don't know if CAR T treatment, it will be beneficial in sarcoma. I don't know. But that doesn't mean that the patient should not be deprived from CAR T if the patient has a diffuse large B-cell lymphoma refractoriness and part of it is a sarcoma. It might benefit the both. I don't know. So that is why there's no literature that I can put forward. But if I have a patient with refractory large cell lymphoma, part of the disease is showing sarcoma, histiocytic malignancy, histiocytic sarcoma, I will definitely entertain the idea of a CAR T if you have the approach. In the United States we have, or a transplant, a consolidative transplant, as you will treat these patients with refractory diffuse large B-cell lymphoma. In that setting, I will have very high threshold to actually deploy a MAP kinase inhibitor or diffuse BRAF inhibitor for these patients, because we know that inhibitor will not help our large cell lymphoma. So that is why you have to know the knowledge of what is the baseline disease which transformed. And similarly, if you transform from Erdheim-Chester disease and you have a BRAF V600E, I will treat with the BRAF V600E inhibitor, because I know that will help my ECD as well.
Right, Dr. Chitima. In your algorithm, you mentioned that the patients who are amenable to surgery, limb salvage surgery, there are examples of patients who are completely cured of the disease, Dr. Chitima?
Yeah. So if you go to Dr. Ruan's treatment, the swimmer's plot, you can see most of the complete responders are actually who underwent surgical excision to localize disease, and the disease has not come back.
Right. Thank you so much, Dr. Chitima. Request discussants, if there are any questions, you can ask Dr. Chitima. I don't see any raise hand signs and no questions in the chat box. So thank you so much for the lecture, Dr. Chitima. This lecture was the last of the 4 webinars on histiocytosis. I really appreciate all the speakers who have spared their time and efforts to educate us regarding a rare and important disorder. Hope to see you all in Goa soon. Thank you so much again, and have a wonderful day. Thank you.
Thank you, everyone, for
Thank you.
Thank you.
Bye-bye.